Hi, hello, good evening, and welcome to our next show. This is a very important topic critical care management in COVID 19. So, at present, there is an epidemic of webinars that you'll be getting a daily link on loads of webinars to follow and subscribe to them. But this is not even a webinar, we are just having a practical discussion from the experts who have already seen such patients. We're not seeing that much surge here still in India, but we need to be prepared. We need to know exactly what's happening. There are a lot of theories floating around, some scientific and a lot of unproven therapies which are being hyped. We need to know exactly from the area where it comes, what it works and what it does not work. We need to have a very clear approach on what we need to do from the practical point of view. So, with this regard, in our program today, we have got two faculty from UK. So let me introduce you to them. Dr. Madan. Dr. Madan is a consultant anesthesia and ICU from Frimley Park Hospital, UK. And Dr. Ravi Saibaba, he's a consultant anesthetics and ICU from Croydon University Hospital, UK. So let's welcome them both. Dr. Madan, welcome to our show. And Dr. Ravi, welcome. Thanks for coming today. So with Dr. Ravi and
inviting us.
Thank you, Dr. Madan. So it's a pleasure. And now I think we'll be benefited by your experience. So with this, I also introduce Dr. Sanjith from Mumbai. Hello, Dr. Sanjith. Hi. And Dr. Sabanayagam is there from Chennai. Hi, Dr. Sabha. How are you?
Good. Thank you.
And Dr. Nandha Kishore is there from Chennai.
Hello.
And hi. So along with Nandha Kishore Sabha, Dr. Manish and Dr. Prasanna will be joining. Dr. Manish, hi. And Dr. Prasanna. Hi, Dr. Prasanna. Hi.
Hi.
Okay.
Hello.
So all good?
Yeah. Thank
you. Okay. So to start with the discussion, just I will ask Dr. Ravi and Dr. Madan how is the situation there, and then we'll step up into the topic. Dr. Madan, if you can start, how's the situation there, and how is the case influx there? Can just,
I mean, our part of the country has been relatively protected. We are just outside of London, so we haven't seen as much a surge of cases that we saw at least a week or 2 weeks before. The case numbers have dwindled down. We probably are in the plateau or on the reduction, but that probably is not the case in central London or just around London. But overall, I think the trajectory is the number of cases or new cases is just falling down.
Dr. Ravi, how's the situation there in your unit?
Situation, obviously, we are part of one of the hospitals in inner London, but also not as big as the other teaching hospital or the university hospital. We're still getting a high number of cases, but since the whole hospital is now has got full of COVID patients. So far in the borough, that area that we live, there are about 1,000 confirmed cases. And in the hospital at the moment, there is about 250 patients with COVID and about 30 patients are in intensive care unit. And we lost about 180 patients so far in the hospital.
I mean, our data is around like 150 patients in my hospital who are COVID positive, of which 14 patients so far are in intensive care, of which 11 of them are on intubated, 2 of them tracheostomy and 1 on non-invasive ventilation. But we have another separate respiratory unit which caters to around 20 patients on non-invasive ventilation. But the rest, 120 patients or so, will be around in the hospital, but are not sick enough to come to intensive care.
Similar to that.
All right. So let's start our discussion. So to start our discussion first, as an intensivist angle, there are a lot of things which has been talked about. Most importantly, the therapies. Everybody is searching for some magic bullet. how they found out some vaccine, how they found out some drug to cure this disease. But everybody knows that that's not going to happen, at least in the nearest future. While having said that, we all know intensive care, critical care save lives. And strengthening the system of critical care, strengthening the care, strengthening the nursing, strengthening the protocols, that itself will give remarkable results, even if you don't have a curative, the so-called the curative magic bullet. With this regards, through an intensivist eye, when a patient come to us, means he's deteriorating. Asymptomatic patient, he develops symptoms, and the symptoms deteriorate to the level that is not able to keep up his oxygenation. But the thing is that we are hearing some stories saying that these patients, they come with cough and cold or some influenza like symptoms, but they are not in distress, they are not breathless. But when you see, their saturations are low. Just want to know, do you really see these kind of patients, or it's just a hype?
I'll take the question on this to start, and then Ravi can share his expertise as well. I mean, we are learning about this disease process. So I would say what we see is from the hospital front. What we don't know is how they are in the community. I suspect there's a lot of patients with silent hypoxemia, but compensating pretty well out in the community. But once they come to hospital, then we identify that with our pulse oximetry and other tests. But when they do come in, they come in as a spectrum. So there is no specific always presentation. Fever, dry cough is going to be there, and shortness of breath is there. But apart from that, there's a significant range of presentation, from totally being asymptomatic, some being quite symptomatic. So we are learning as we go along. Lot of patients present with this hypoxemia. What sort of numbers that you tend to accept as needing intervention changes day by day. So for example, you could have a patient who's comfortable at saturation of 80. Then what do you do next after that? So do you intervene? Do you intubate? But they appear very comfortable. This is a very common scenario that we are facing in this type of patients. Whether this is the earliest stage of the disease and then they progress to a totally different stage, we really don't know. But a lot of patients do present like that, where they are pretty comfortable but are tolerating very low level of saturation.
I agree with Madan. Yeah, I agree with Madan. Having said that, just one thing. A couple of my colleagues have turned out to be COVID positive recently. Yeah, my ICU colleague. Yeah, one of them had a really bad time, and the other one managed to get around well. So just we thought, okay, each of us will have a pulse oximetry at home, and then check our saturation at home, how we are, and then. Few of the days, one of my colleagues had saturation 92, 93 on room air at home, but he could still have a proper conversation without any shortness of breath. So you could see the difference. What is that silent hypoxemia? So if this is what happened to previously fit and well healthy chap at home, having a saturation of 92, we don't know how many people are there in the community with a saturation of 85. And we have seen people coming in, walking in, to the hospital with a saturation of 65 and 70. They come to the hospital walking. Yeah, so it's something different which we haven't seen before, or which we haven't read in textbook before. So, and as we went along, we learned so much about this condition. 3 weeks ago, 4 weeks ago, saturation of 85% on a FiO2 of 60%. Yes, we were intubating straight away. We're not even looking at work of breathing. 85, 60%, that's quite low. Tube them. But as we went through the last 3-4 weeks, we have found that we have to see the work of breathing, and if you can find out any other avenues to avoid or prolong the intubation thing. So that's where we are. So it's an interesting thing.
So this silent hypoxemia is not a hoax. It happens, and you are seeing such patients.
Yeah.
And previously, you said that when the saturations were low, you just straight away put the tube. But now that when the work of breathing is not really great, you are just observing even those
You're
patients.
observing. Yeah.
Dr. Sanjith from Mumbai, what's the news? How are you seeing such patients? Unmute your mic, Sanjith. Unmute your mic. Yeah.
Is it okay now?
Yeah. Okay.
Is it okay now?
Yes. So yes, Sanjith.
All right. This is exactly how it was. This is exactly how it was when we met the last time. The last time that I met, I was rushing around and trying to intubate patients, looking at a saturation of 80, 82. I used to feel that the respiratory rate of 40 is problematic. For me, it was not problematic for the patient. So it's right. There is something called as happy hypoxemia, and this is one of those category of patients that fit into that. Now, at this moment, I have 7 patients in the ICU, and all of them, sizable number of them, almost 3 or 4 of them, are at a saturation of around 84 and 83, and I'm not rushing into intubating them. I just realized that intubating them is like more dangerous than actually leaving him at that. So it's doing well by not intubating them as of now. Yeah.
No, but how's their work of breathing? They are absolutely comfortable, or they are
So
at an increased work of breathing and still compensating for that?
no. So what? Yes. So what happens to them is that they are talking to you. Respirator of 35 and 36, they are actually talking to you. They are talking. They are having their food. It seems a very different kind of a situation. They are talking to you. They are answering your questions. But the patients at which I am actually trying to intubate is the one who has extremely large inspiratory efforts. It's only when the inspiratory effort goes up that I'm really trying to go and intubate them. It's not the metric is not the respiratory rate. The metric is the effort, the
Okay.
inspiratory effort. Initially, we all thought that if the saturation was low and the RR was high, we intubate, but that's not the metric at all in this kind of disease.
Okay. Dr. Sabha, you have something on this?
Yeah, I mean, it's quite interesting. I mean, most of our hospitals over here, we're still waiting for our patients to come in, especially the private hospitals. I don't know if whatever the government is declaring over here that our lockdowns have been working quite well. So we haven't started seeing very sick patients yet at the private hospital levels. Of course, a few of my friends in the government setup are seeing some patients, but nothing close to anything what our friends and colleagues see in the Western world. I mean, from Sanjith, I understand that he has started seeing patients over here. Yes, we do see every patient whom we call as COVID suspect. We take them in. We do a standard treatment like how we do for any other community-acquired pneumonia. We test them. I haven't had any patients tested positive in the last few weeks, and we haven't had any severe respiratory failures except the one that I had last night, whom I had to rush and intubate. Yes, but that patient is behaving like a straightforward community-acquired pneumonia that we would normally see. So the CT findings suggest some ground glass opacity suggestive of viral pneumonia. So we have a dedicated COVID ICU over here, and we are managing these patients in that ICU. End of the day, we haven't seen many patients to share my experience or anything. I guess I would just go with what my friends and previous colleagues from the Western world share with me.
And Dr. Ravi, another thing is when you do gases for these patients. So one of our viewers also asked this question: how about their lactate? Is there any evidence of cellular hypoxia? Or now, what is happening with their gases, or how is the end organ function when these patients are silent hypoxia? You're saying that they're comfortable, they can talk with a low saturation, but how is the end organ function? Do you see elevated creat, acidosis, or lactate? So how do they behave that way?
So, bizarrely, I haven't found any raised lactate, only maybe 1 or 2, and that turned out to be a DKA patient with high lactate. And with regard to the end organs, I've seen pre-renal failure, and the renal failure happened after they got intubated. So pre-renal failure can be seen because these patients are unwell for about a week, 10 days before they end up in hospital with so much dehydration. And lactate, I haven't seen at all. They're all 1.5, rarely touch 2.
I would agree with the view that the lactate is normal, pretty much normal, unless you are on metformin, which probably causes a lactic acidosis. Most of these patients are type 2 diabetic or have got morbid obesity, so they tend to be on metformin. And again, whether they have diabetic ketoacidosis, which is triggered by the COVID infection. So that possibly can raise the lactate, but lactate and cellular hypoxia is probably a very late event. It may rise if the patient's probably having a quite significant respiratory effort, but that's a very late event. It's not seen early at all.
So in this subset of group, who are happily hypoxemic or comfortable at rest, you are not seeing any end organ damage, and by seeing only the saturation numbers, you are not intubating the patients. If and only if the patient's work of breathing is high, it's not work of breathing doesn't mean that they're tachypneic. If they're tachypneic and they're talking, then you tolerate, you manage them conservatively, accepting a saturation as low as 80%. So this is what we
can't put a prescriptive number on the saturation. Okay. What is tolerated for an individual person has got to be individualized, because otherwise people may make wrong decisions. In our guideline, what we have put in is between 88 to 92%. So we aim for around that range, but the range can be lowered depending on what you see in front of you.
Okay, so that's what we learned. There could be asymptomatic patients, there could be asymptomatic patients whose saturation will be really low. So this is what we see. And if these patients or some other patient who was not in that phase, it develop breathlessness with increased work of breathing, obviously we'll be giving supplemental oxygen. So with supplemental oxygen, few improve and few doesn't improve. So what will be your strategy at this point of time? If they improve or if they don't improve with supplemental oxygen, whether you go straight away with intubation, or now also you accept a certain amount of increased work of breathing and continue conservatively, or you try non-invasive ventilation and then go for intubation or high flow nasal oxygenation.
This is a very, very complex scenario with so many different variables in this equation. Yes. First is you got a few options. First is the amount of oxygen that you're going to give them. What is the response to it? Second thing is the consciousness level of the patient and how tired they look. So if they are getting exhausted, and what is the exit strategy, in the sense how far away in the disease process they are. So and the response to proning. So these are the parameters that we tend to use. So if you give them a reasonable amount of oxygen, then you'll be able to establish whether this is purely because of shunt. And then if you try proning, then you know that are you able to optimize the VQ mismatch. And then the next step is if you use low level of CPAP, and then you're able to assess the recruitment capability. So based on a combination of these three factors, you'll be able to see how much of an improvement in oxygenation has happened. And from that, you'll be able to make a judgment. So if the patient's work of breathing gets better, the patient appears less distressed, is stable on low levels of PEEP, then you'll accept a reasonable oxygen saturation and continue with self-proning as an on and off.
Okay. So with this regard, I just want to ask you a question, because when the disease was first in China and when we are getting reports from China, we were under impression that late intubation resulted in poor outcome. When these patients, when things are not working after a brief trial of supplemental oxygen, they were going in for early intubation. So we were under the impression that because of the other issues with NIV and high flow nasal oxygenation, namely the aerosol spread, it is a theory or it is a myth, we don't know, but it can disseminate aerosols, especially when we don't have negative pressure rooms. Early intubation was the key to improve the outcome. So that was the impression we had. But later on, when the disease spread to Europe and America, the European people from, especially from Italy and others, they were using non-invasive ventilation for these patients. So, does that really hold now also? Because if you don't intubate the patient early, if you wait and the patient deteriorates and then you intubate, such patients are not going to do well. Or the scenario has changed that without even intubation with non-invasive ventilation, you can these patients can improve and show a better outcome. So, what? How is the scenario there, and what is your experience, Dr. Ravi?
Yeah. So initially, when we started, when it hit at 4 weeks ago, we had a similar kind of thing. We found what the Chinese said, like early intubation. That's the way to go. And then we started intubating people earlier. Like as soon as they hit 60-70% FiO2 and the saturation is not going beyond 80-85, we were intubating earlier, but not very good results. And then the Italian evidence came that because their evidence was forced in the sense they ran out of ventilators, they were forced to use CPAP, and they found a relatively better result in the CPAP thing. And the issues were with regard to the aerosol generation, as you mentioned, about using NIV and high flow oxygen and lack of negative pressure rooms. Even we don't have negative pressure room here. So what we decided is, okay, we have to try and look at these patients by putting them on CPAP machine. So what we did is we cohorted all these patients in a 6-bedded or an 8-bedded ward, okay, with all the patient, all the staff who are going to nurse these patients in full PPE gear. And we found relatively better outcomes. If you look at about 50% of the patients did very well compared to the intubated patients. So at the moment, the data from UK ICUs is like, if you end up in intensive care, ventilated, you got about 70% mortality. But these patients are doing much better. And some of the patients who were deemed not candidates for intensive care, they got better and then got out using CPAP alone. High flow oxygen we haven't used, but if you have an isolation room with negative pressure facilities, you can use. At the moment, we are tied up for not using high flow oxygen because of the demand in oxygen in the hospital. And that is also part, again, resource oriented. Because at any given point of time, because of all the huge amount of oxygen being utilized, the oxygen bay the hospital is using is quite close to 90-95% capacity. So based upon that, we have to cut down on high flow oxygen as well. So from our side, as Madan mentioned, each and every patient is different and individualized. So you look at them, you observe them, and you give them oxygen, self-prone, push them to self-prone, and try them on CPAP, and then review them regularly, see how they are, and also their markers, particularly the lymphocyte count and the CRP, how they're doing along with chest X-ray, and then take things from there. But half of the patients who are on CPAP, they are doing better. And then once they fail, obviously we take over. That's the tricky bit. Once they fail, what you're going to do? We'll come to that when we discuss further on.
Yeah. So you mean to say that unlike in China where they advocated early intubation, you are now going slow as you're continuing with non-invasive ventilation, and then you're reserving your ventilated beds for patients who don't improve with non-invasive ventilation.
Or patients who come in a bad way to emergency department.
Yeah. So directly intubated. Yeah. So Sanjith, is that the strategy you are having there, or you have a different take on this?
No, it's exactly what they said. We try to not intubate our patients for a long period of time. And fortunately for me, I got helmets in my unit, so I am using helmet as CPAP. I think NIV is not a kind of a modality for this kind of illness unless there is concomitant COPD or something like that. It is NIV in the sense BiPAP. It's only CPAP that probably is good enough because it tries to take away the atelectasis part of it that results because of low tidal volumes. So we put the helmet on, and surprisingly with the CPAP, these patients tend to do a little bit much better. In fact, we don't have the surge in our hospital, so we still can use oxygen. So we're using high flow nasal cannula also, and to think about it, when you cough, you're actually liberating 400 liters per minute and huge aerosols. So when you put a high flow, it's barely around 30 to 60 liters per minute. And putting a mask on top of it with a high flow nasal cannula, of course, there would be some change in the dynamics, but that does help quite a bit to avoid intubation. The high flow nasal cannula is helping me quite a bit in these patients, definitely. So I've got two high flow nasal cannulas and one helmet, and I keep using that again and again. It's helping me a lot. Yes.
So, what all the experts believe that there is no need to rush for intubation, especially early intubation. We can give a trial with the CPAP or high flow nasal oxygenation if the condition permits. Having said that, we need to cohort these patients because we all know that aerosol generation is a possibility during these kind of modalities. And Dr. Sabha, you want to add anything on this, or you have any queries on this? You want to ask them?
No, I mean, fully agree with that. Previously, our thought process has been quite different. Like what you said from the China experience, almost 90% of them failed NIV, so they all got intubated. So we all were under the impression that early intubation is the key. But having said that, now we start getting more and more evidence from the Western world. Our strategy has also changed. So once we start getting in patients, I guess this is what we'll be doing. And more going with more of clinical parameters rather than just the numbers alone. Yeah, I fully agree.
Dr. Manish, you have any take on this?
No, I also believe that if we can avoid intubation for certain time, that because not only that there is no evidence that early intubation or early ventilation helps, but intubation and ventilation as such will cause secondary infections, ventilator associated infections, and they may worsen the prognosis. So that mechanical ventilation should be used only when it is imperative. We should understand that ventilator is to replace the breathing system and not oxygenation.
So, are you using awake proning of these patients,
Yes.
Dr. Ravi? Yeah.
Yes, we are using awake proning more and more the last 3 weeks, actually. It needs a lot of patients. Patient need to agree for that, but you have to find a way to force them to do it. Okay, and again, the staff have to make sure. The obese patient is always a bit difficult for the proning, but you can put a couple of pillows on your chest and pelvis to improve their exertion of the abdominal muscle. So we are using more and more, and as soon as you put them self-proning, you could see a massive difference in workup breathing. That's the subjective thing that you see, and objectively there is improvement in saturation as well. So we are using more and more.
I mean, even if full proning is not done, we tend to just go for semi-prone as well. So a couple of pillows to support the knees, and then you just go semi-prone. Patients are happy with that as well.
Okay. So what we are seeing now is we are getting reports and cases like the disease process itself is not the same. There are cases where we get a different kind of picture. The different they name those as phenotypes also, high and H and L, and the CT scan finding is different. And one kind of phenotype where there is high, they don't respond to recruitment maneuvers very well, but the other type which behaves as a typical ARDS with low compliance, they behave as the standard. They behave very well with the standard ARDS protocol. So, what's your take on this practically? Do you see really such things, and do you do CT routinely for all these patients? If you do CT, when do you time the CT to differentiate between these kind of phenotypes, and how do you target your therapy? I'll first go to Dr. Madan, and then I'll come to others. Yeah.
I mean, having a CT scan right at the start of presentation is an ideal method. That's how China used to do for all their patients. That they had CT as a triaging tool. But in places like us, where CT and then cleaning the CT scanner afterwards, it's not going to be practical. So we don't rely on a CT scan. A clinical presentation and chest X-ray findings is good enough, and lung ultrasound is very sensitive. So if you use a combination of these factors with a clinical presentation, it is good enough. We are still grappling about the disease progression. So it is hugely possible that the L phenotype may be just the early stage of the disease, and the HP phenotype may be the late stage of the disease. or the other way, the
H.
the one where the lung is not stiff is the early stage. The high compliance is the early stage, and the low compliance is the late stage of the disease. Or we don't know whether early intubation and then causes enough lung injury that it pushes the L phenotype, the high compliance into the low compliance stage by itself. So we really don't know the answers. Only time and data will tell later. But it may possibly just be the natural progression of the disease.
Dr. Ravi, your views on this phenotype?
So as mentioned about, we are seeing patients in both spectrum. Okay. Initially, when they start, they behave not like an ARDS pattern. So initially, they have good compliance. You go around and see, oh, this chap has got a compliance of 60, 70. And why he is not oxygenating well? Why is hypoxemic? So for those patients, what we have kind of agreed, or what we are doing, is you target a bit higher tidal volume, about 6 to 8 ml per kilogram, instead of just sticking to 6. And then we try not to give too much P, because these patients need FiO2, not too much
I'll come
P.
to that ventilation part later on in our discussion. So you are seeing these kind of phenotypes in your practice?
Yeah.
Okay.
But what we think is possibly the H phenotype is possibly progressing into L phenotype as the disease progresses. Because we have got patients in both the spectrum. One whose compliance is good, and there is another group whose compliance is bad. Yeah.
Okay. Dr. Kishore, you have something to ask about this? Yeah.
No, it's we see. Actually, we have not seen the patients yet so much. So it's nice to get the information from people who are experiencing it firsthand, like Dr. Ravi and Dr. Madan. See, I mean, like if you said the patients who are ventilated move on from the H phenotype to the L phenotype, or from more complaints to less complaints. Have you seen such changes in patients who are not intubated as well? Have you seen a sequential CT and seen any difference in the changing of the pattern in non-intubation? Just to show that probably we are causing more harm by intubating. And is there any sequential CTing? Would it help in these sort of patients?
So doing a sequential CT should help, but unfortunately, because of the resource constraint and also not having a dedicated COVID CT, we were not able to do more than one CT at the moment. Even out of 15 patients in the unit, only 3 or 4 patients managed to get CT. Yeah. So,
Okay, what about patients who are not intubated? Have they progressed from H to L as well? Have you seen that happening?
People who stayed in the hospital for longer time. So there are one group of patients who stay in the hospital for about 4 days, 5 days, get better, and they go home by 7 days. But people who tend to stay in the hospital for longer time, for example, take 7, 8 days, and those patients, when they end up intubating, either they might be on oxygen or CPAP, they're invariably, most of them are L phenotype. So that's possibly maybe the disease is progressing. We don't know.
I mean, I would agree with Ravi on that. Is that those patients that fail non-invasive ventilation have a sort of a disease progression, who after a couple of days trying non-invasive, they're still stuck, they haven't improved, which then means they're then going to progress to the next stage. So when is that cutoff of them transitioning over? Probably a CT may help. If they show dense consolidation, then they have moved over into the low compliance category. So just to make it clear, I'll just tell that this L and H is a bit confusing. So I just kept it in my mind as L is low elastance, which is high compliance. H is high elastance or low compliance. Okay, so basically they just confuse you a lot. So let's just keep it simple as high compliance and low compliance. People progress from high compliance to low compliance. That is, low compliance is like ARDS. High compliance is where it's like a big shunt.
Right. So
if you do progressive CT scans, you would probably notice this change. It may help in triaging what category you take. We reserve CT scans only for the refractory hypoxemia ones, but on them too, we don't do CT alone. We do CTPA. What we have noted is a significant incidence of segmental and subsegmental pulmonary thrombosis, which actually worsens the situation. In addition to the ARDS picture, they also have a lot of thrombi, pulmonary thrombi. So if you see in early, there may be microthrombi, I don't know. But what I have seen is a lot of segmental and subsegmental thrombi, and they end up in therapeutic anticoagulation. So that probably worsens the situation.
Okay, so that is also a theory which is floating around that the lung parenchyma is relatively preserved, but you're seeing a lot of thrombosis, microthrombosis, and as you said, segmental thrombosis. There are some patients of COVID also landing up in thrombotic complications like MI and stroke during this period. So it is a bit of a thrombogenic state. Having said that, is that not common even with a typical ARDS where you get microthrombi and stuff like that of other etiology? Even in other ARDS of other etiology, we do get pulmonary vasculature problem, isn't it?
I mean, I haven't seen it to this extent, is what I would say. Early in the course of the disease, like at presentation, I've seen a couple of patients where they had big right heart, and then we then saw that there was a clot floating in the right atrium. So then we then went on to straight thrombolysis. So this was on presentation itself. So extremely hypoxemic, but having a big clot in the same. She wasn't only a PE; she was a COVID plus a PE.
Okay. So this brings me to a very important discussion of theories floating around why this COVID patient is hypoxemic. Because a lot of death were observed in patients who were intubated, and so many theories floated around in the net. Some published, some not published, some written by non-medicos. Can you believe it? So there are a lot of therapies, and even our viewers, most of them are asking about that. Is it like behaving like a high altitude sickness? Is it behaving like something like a carbon monoxide poisoning or methemoglobinemia? Is there a hemoglobin theory where the virus displaces the iron and it forms some bonding with porphyrins and doing something? That is why there is a desaturation? And there are although most of the things created a hype in so many things that it's a misinformation rather, and we don't have a profound scientific evidence for that. So what do you say about these myths or really exist? And when I talk to people, so many people say this is COVID patient means we should not intubate, we should just give blood transfusion. Why blood transfusion? It increases the hemoglobin, thereby improves the saturation. This kind of message, even medicos maybe of junior levels, they are talking about this. Now we need to give plasmapheresis so that it will remove all those bone fragments, and this kind of things is happening very, very virally. Some of the posts have been removed, and something which is written so very well in English that catches the audience attention, and even non-medical groups discussing about this, that ventilation is not the treatment for COVID. We know ventilator has saved million lives. On one side, every country is discussing about procuring lot of ventilators, whether we will be able to provide ventilator support to all the patients when the disease becomes reaches the plateau. On the other hand, ventilation is going to kill. So this is kind of this is a kind of strategy which is based on all these theories. And many of our viewers are also interested in the theory of hypoxemia. What exactly causes this hypoxemia? Is it really the gas exchange that problem like in typical ARDS? Like you said, there are some pulmonary thromboembolism, that kind of phenomenon which causes increase in shunt and dead space ventilation. That's also a problem. But how to debunk these theories? So I'll go to Dr. Ravi and then I come to Manish after this. Yes, Dr. Ravi.
As you start,
have you heard of these theories? Because in India, WhatsApp, it's spreading a lot.
So it comes in WhatsApps and non-medical stuff quite a lot, isn't it? So as you said, clearly it's a theory, and we don't have any evidence to say whether it binds to heme or globin. We don't know the evidence as such. But what we know is there is a massive shunt, there is a ventilation perfusion mismatch. So these are the things that we know, and definitely oxygen helps this patient. So at the moment, this is what we have. So I would leave it to the researchers to find out the theory driving all these things. For example, about your heme binding and all those things. At the moment, I don't have anything to add on what you have said.
So this post was particularly very popular, and it went viral around. So many people started asking. But of late, some people are, on one of this article also, it came in Kim Ricks or somewhere in the gym. And now there are articles where the real scientists are pitching in, and they're trying to clarify that this is bullshit. And Dr. Manish, you have a take on that? Yeah.
Leave alone the absence of evidences, it does not seem to be plausible also. In this condition, we have seen that there is no viremia. There are very few virus in the bloodstream. And to attack an hemoglobin, they have to be in the bloodstream. So there is no increased attachment of these virus to hemoglobin or RBCs. There are very few virus in the RBCs also. So we know that. So it does not seem plausible also that it is because of the changes in hemoglobin. So I don't think it is correct to say these things. It is better that we should base our treatment plan on evidences that are available to us, or at least the people who are actually doing the work and seeing these patients. We should take the help of them and their expertise, rather than believing on people who are sitting in the drawing room and writing so many things.
Okay, Dr. Sabha, you're smiling all the way. So, what is your take on this?
No, yeah, I fully agree with Dr. Manish. I guess with the Western world, I have friends over here. They are actually in the war ground treating patients, and I would value their experience million times more than what I read in the WhatsApp. I don't have any disagreement with what Dr. Manish said. But having said that, I feel like somebody who's been sitting in the dark, waiting for the unknown enemy, waiting for him to come. For the past 4 weeks, we've been sort of prepared, waiting for our patients, but we haven't seen that many, luckily, thank God. But as the intensive care teaching goes, audible? I'm still audible. Okay.
Yeah.
It's not about...
I think we lost Sabha, so let him get
audible?
in.
Sorry, my
so,
video keeps
having
going
said
and
this,
coming.
he's coming. Yeah.
Okay, sorry. I guess the as the intensive care teaching goes, it's just giving the entire package to the patient, rather than just looking for a particular cause and a particular treatment. Like most of the diseases, like what we have now, COVID-19, it's just, we just have to give the entire package. You see pulmonary microvascular thrombi, yes, you go on ahead, anticoagulate them. You see ARDS like picture, yes, you go on ahead. If they need oxygen, give them it the best way. If they need intubation, go by clinical decision, intubate them. I guess that's what intensive care teaching goes, and I guess that's what our friends and colleagues in the Western world are doing it the best possible way. So all these theories keep floating around.
Dr. Sanjith, what's your take on all these things? Is there a different theory, or it's just the gas exchange, the routine stuff that we have to handle? Oxygen helps, ventilation helps, but do it in a perfect way and select the patients in a perfect way.
So
yes,
I'm a little bit fortunate enough as of now, because doing a couple of CT scans on a large number of patients. I am doing that. I'm doing a couple of CT scans on almost every patient that enters into the hospital. So I'm trying to study what's happening. Find these multifocal peripheral ground glass opacity with alveolar septum that is kind of thickened. And somewhere around day 7, day 8, when we are following up these CT scans, we are finding them to become confluent. Our threshold to do the CT scan is actually, it was always that we do the CT scan along with an RT-PCR. But now we're also repeating a CT scan somewhere at day 8 and day 9 to understand where we are actually going. And when we are having said that, there are 3 kinds of patterns that we have noticed. One pattern is the one that has got peripheral opacities, and when you do a lung ultrasound, you're seeing these pleural shadows with some pleural lines going downwards and some V lines. Whereas the other variety is the multi, like the ARDS clear variety, And the third variety is a variety with very minimal pleural effusions with baseline atelectasis. So I think there are three parts to the story. So the ones that are hypoxic and their lungs appear to be pretty okay on CT scan probably are the BQ mismatch variety kind of situations where there is pulmonary microthrombosis. So a combination of a high D dimer and hypoxia with a CT that's relatively normal is going towards pulmonary microthrombosis. And as one of the speakers mentioned, that's probably the one phenotype that we are probably looking at. So CT, I'm utilizing CT, and I'm grateful to have understood the disease a little bit, at least from a very small part of experience, because of the search that has not yet come in, I still have the time to do that.
Okay. Okay. So now, so all those theories are floating around, but we all know that, we all hear from the experts who are really managing the case that it's oxygen. We have to give oxygen to the patient, and ultimately the oxygen should reach the patient blood, and it's a gas exchange where we need to target, and there are no proven evidence to show that the other theories like viremia causing the hemoglobin ion to displace all those things doesn't hold good. So based on that, there are a lot of therapies which has been proposed, like transfusing blood, plasma, hyperbaric oxygen, whatnot. So we'll all discuss that at a later stage. And now there is a just generalized statement that intubating and ventilating the patient is going to do more harm. So this will be discussed in detail, saying that we have to have a stepwise approach. There are patients who are silent hypoxemic, and if the patient is deteriorating, then we have to try and manage as much as possible without intubating them. Then if a scenario arises, then we have to intubate the patient. Intubation is the treatment. But forgetting all those things, there's a generalized statement stating that intubation is harmful and intubation is not going to benefit the patient. And the media also hypes that. And when you see the Italian outcome study, if you can see there, with the number of patients who received in the respiratory support, out of 1,300, 1,150 were having invasive mechanical ventilation, and only 137 of them were in non-invasive ventilation, and with O2 mask only 13 number of patients were with O2 mask. So there's a significantly higher number of patients who required mechanical ventilation in their outcome study. And the outcome study also shows something about the mortality, but not all the patients had a outcome. Out of the 1,500 admission, only 16% have survived to ICU discharge. And over 60s, if the age goes up, it's only 10% who survive to ICU discharge. 26% in this series have already died, but still 58% are still in the ICU. So it's bit alarming. It's bit alarming to see the outcomes. So having gone through all these things, and with this outcome study from Italy, let us discuss something about the ventilation strategy. And finally, we need to intubate these patients because they don't do well with the trial of non-invasive ventilation or awake proning or high flow oxygenation or CPAP, as Sanjith told. When we have to finally intubate this patient, what should be our strategy? And having known about the phenotype also, they said there is a phenotype where it is high. That means the lung parenchyma is relatively okay, a lot of thrombosis. There is a phenotype which is L, where there is a damaged lung parenchyma and the gas exchange is really a problem. So what should be our ventilation strategy? What should be our initial settings? Dr. Madan, will you take this question?
Okay, I'll try my best to answer. As we discussed at the start, the good compliance patients probably are okay with slightly higher tidal volumes and a lower PEEP strategy. So unlike the conventional ARDS teaching, which we tend to use as our guiding principle, they probably are not the right strategy for that type of patients, is what the message that we're getting across, and probably what we're seeing as well, is that you may probably be able to relax off the PEEP a little bit and probably compromise on the FiO2 scales and decouple the PEEP table. Okay, and use a slightly higher tidal volumes because the compliance is good. On the contrary, when you move over to the more stiff lung, where the compliance is very low, then you stick to the standard ARDS principles. What type of ventilation you choose probably all don't matter. What matters is that you stick to the key principles, that you allow permissive hypercapnia, allow permissive hypoxemia as well. That is, you accept a slightly lower target than what you would do conventionally. Probably 88 to 92 is an acceptable target. And then, as long as the pH remains within normal limits for permissive hypercapnia, and use the lowest driving pressure, and maintain. We use a ventilation strategy called the airway pressure release ventilation, which, along with proning, we have seen very good results with it. So, and that's what, and you limit the plateau pressure as low as possible. Okay, so if you stick to those ARDS ventilation principles, probably you're causing the least amount of harm. And especially when we are proning, we try to use neuromuscular blockade and relaxation so that we don't have high driving pressures.
So we'll come to proning next. Before that, I'll get the opinions from Dr. Ravi as well. Dr. Ravi, what will be your initial strategy? What will be your initial setting, and how would you titrate your strategy on seeing the response?
As Madan mentioned, it's pretty much the same strategy that we are using as well. So initially, when you think the compliance is good enough, then you go for a little bit higher tidal volume with a P less than 10, but you go up on your FiO2. Okay? So that's, but when the disease moves to a low compliance for the phenotype L, you go with your ArchNet protocol. You aim for a much less tidal volume, and then you limit the plateau pressure, accept permissive hypercapnia, and go for PaO2 of 8 and PCO2 of 8 and pH of 7.2. So you accept that when you go towards the ARDS. Yeah.
So you're not strictly adhering to the ARDS protocol for blindly all the patients, depending on the compliance and depending on how the oxygenation improves, how the oxygenation improves with recruitment managers. You're okay with the low PEEP as well, and relax the PEEP and increase the FiO2 to maintain the oxygenation. Am I right, Dr. Ravi? Yes.
So initial settings, if it is a high H phenotype, is what you do in operating room. You go for a PEEP of 5, 6, 7, not more than that, and the tidal volume of standard 500, 550 if you give your anesthetic. So similar to that, and ARDS for the L phenotype.
Okay. And Dr. Sanjith, your point.
Yes, yeah, so I don't have the kind of experience that my counterparts at UK have, but I have a working ventilation strategy which has been there for a couple of patients that we've ventilated. So what we do is as they rightly said, I target a tidal volume somewhere around 560, 550 to begin with, at a PEEP of somewhere around 8, put them on volume control mode of ventilation, and then look at the driving pressure. Once the driving pressure is in 15, I consider to get down the tidal volume by around 6. Then I measure the compliance. If the compliance is less than 40, that is the patient that I'd use my ArchNet PEEP table or probably APRB or the CPAP maneuver to recruit the lung. But if the compliance that we're using and the targets are saturation of around 88, carbon dioxide of around 65, and plateau pressures of around 30, this is what we're looking at. Yeah.
So, the another question about prone ventilation. When the initial strategy is not working, then how early you prone the patient, or you wait till you exhaust all your PEEP and then you prone the patient, or is prone ventilation really working, or it is hyped a lot? Dr. Ravi?
I could say this is the only thing that is working well at the moment. So what we are doing is, as soon as they get intubated, and once your lines are all in, your NG tube and catheter is all in, we straight away prone. So when we started initially, we were thinking whether we should prone or not, starting off, but now we are proning early and we're doing it more and more. Initially, we will thought, okay, give 1 or 2 proning. Now we are proning people 4 sessions, 5 sessions of 16 hours each. Quite labor intensive, but it seems to be working. And it is the only thing that is working quite well. Yes, it is not working for all the patients, but most of the time you prone them, your FiO2 requirements drops down to 55, 50, And then when you deprone them for 8 hours, it goes up to 70. But if you keep doing it for 3 or 4 times at least, you will see a difference in most of the patients, but not all the patients. That is what we are seeing practically. But once they are too far down the ARDS route, yes, you might not see the difference.
Okay. So what I'm asking is, when you are proning the patient, or even after intubating the patient, are you seeing a change in the hemodynamics? Because when you before intubation, they'll be in a bit of compensated stage with tachycardia and maintaining their blood pressure on their own. Once you give a lot of sedatives to synchronize them with the ventilator, or are you seeing an exaggerated hypotension, thereby using a lot of fluids, vasopressors, and thereby predisposing them to end organ dysfunction? And adding proning uh, adds one more insult to the hemodynamics. So how are these patients behaving, just to have a experience on that? Yeah.
Compared with your chest sepsis, proper sepsis, these patients are relatively stable from the hemodynamics point of view. That's what we found out. You're on a lot of sedation, and still they need more sedation. So you exhaust your propofol, fentanyl, and then a lot of times you move on to midazolam, and then eventually end up paralyzing. For whatever reason, these patients end up having high metabolic rate. And I have very rarely seen patients having huge amount of vasopressor requirement. Yes, they do need NORAD, not 0.1, not 0.2 mics, but not to a range where you end up adding vasopressin on top of NORAD. So most of the patients that we have been involved, not all, as soon as everything is sorted, once they become stable, and once we're given a bit of fluid, we prone them within 3-4 hours very quickly.
Dr. Sanjith, what is your experience of the hemodynamics once you intubate the patient?
Yeah, exactly. It's the same way that Dr. Ravi reported. I mean, the couple of patients that we've done, they just have lung issue. They don't have. It's just the lung, and the beat remains rock stable. The pulse remains rock stable. Pulse doesn't move. The pulse rate just remains the way it is, and they require tons and tons of sedation. It's something very very unique to these guys. I mean, we really have to sedate them to put them down, and nothing happens to the blood pressure. Nothing happens to the blood pressure.
Oh, that's interesting. And Dr. Madan, you have anything to add in this?
Exactly the same picture. They cough a lot on the tube, so you end up going on the opiates quite a lot. So they're very difficult to sedate, and the vasopressor requirement is predominantly due to the use of sedation rather than anything else. But if they develop early hypotension, then probably I would recommend scanning the heart and to see the right heart function, and also to send off a set of troponins. So if there is, I have seen 2-3 patients with viral myocarditis where the troponins were in, one patient had 16,000, another patient had troponin of 5,000. So they had early viral myocarditis. That can complicate the picture. And the second thing is, if you start to see evidence of right heart strain, then probably.
Okay, there is some connection issues. Dr. Sabha, you have something to say on this, or something to ask the panelists?
Yeah, it's quite an interesting phenomenon that people notice that the sedation requirement is quite high. Really see in those patients on ECMO, where the theory is that all this sedation gets trapped in the ECMO circuit, and as a result, they require a lot of sedation. I just wonder if there is any need of, like Ravi or Sanjith or Madan might answer, because you see patients. Any possible reason why they require so much of sedation?
Dr. Madan, we lost you in between. So any possible reason? Yeah, there is increased need for sedation.
I suspect
is there the airway reactivity?
That is one possibility, and the second thing is probably they are hypermetabolic.
Hypermetabolic.
Because they have a very high temperature, they probably degrade the drugs a lot quicker. So that's possibly the reason.
Okay. So coming to the kind of like you talked about troponins, there are a lot of biomarkers from the Chinese study. We saw that they were using ferritin. They said the procals was not that high in these patients. It always remained low in most of the patients unless they had secondary infections. They were doing regular D-dimers and stuffs. So do they have any role in strategizing our therapy, or do they give any prognostic marker or an indicator? What is all this? What does ferritin do with this disease, and what is what is all these about? Do you do regularly all these stuff, Dr. Ravi?
Okay. With regard to the markers that have got some prognostic significance, it's the low lymphocyte count. And if your lymphocyte count is not going up after a few days of therapy, you could see it will kind of mirror how the patient is improving. And then CRP that is not budging. So persistently elevated CRP in spite of being on ventilator, then that is again a bad marker. So with regard to the D-dimer, we do on the day of admission, and then we do repeat every 48, 72 hours. So recently what we have done is we're looking at a D-dimer number, and based upon that, we decided, okay, let's anticoagulate these patients. Okay, based on D-dimer number. And any patients who end up on filtration, we are systemically anticoagulating them. Okay, and the ferritin, what we are at the moment using is, unfortunately, our hospital don't have access to procalcitonin. So that's why it works here. So serum ferritin, we are looking at it at day 1 and day 7 down the line, and we see any different or increasing serum ferritin. And based upon the serum ferritin, we are making a decision about whether to give steroids down the line in spite of when the patient has got cytokine storm and all those, which will come back, which will come later. The serum ferritin, high serum ferritin is not good, low lymphocyte count is not good, high CRP is not good, and ongoing temperature in spite of treatment, these are all indications of your cytokine storm that is happening.
Okay, so there are some strategies which you can titrate based on these biomarkers. I'm surprised to hear that you don't have procals there. Here we do regularly. Dr. Sanjith, you have anything to say on that? Ask about that, about the biomarkers and how they influence our strategy of treatment.
So every 3 days we end up doing CRP, D-dimers, procalcitonin, LDH, and LDH. Yeah, these are the things, and lymphocyte counts. So as he rightly put it, we are trying to find the step up that we get. If the D-dimers go from a low level suddenly, or the LDH goes up markedly by 400s, 500s, something like that, CRP remains on the higher side. We're trying to pick up those patients who might be the cytokine storms, who might benefit with those small doses of steroids for some time. Yes, the real attempt being to prevent them from getting on the tube. So I feel the D-dimer works that way. Also, we're using the D-dimer as a marker to do a CT pulmonary angio. I mean, if the D-dimers do go up very high, then we're doing a CT pulmonary angio just to be certain as to we're not missing out something. And as you rightly said, putting on therapeutic anticoagulation. Yeah, that's what we do.
Okay. Dr. Madan, what are the things you are using? And
we are using pretty much everything. We are running out of D-dimer, so we tend to use D-dimer only as an on and off basis, day 1, day 3, day 5, something like that. But D-dimer, we used it to stratify for anticoagulation. Procalcitonin, generally it's very low at the start. And if you get a rise in the procalcitonin or the temperature is not improving, then we look for secondary bacterial infection. We send off again cultures and blood cultures, bronchoalveolar lavage, and then we treat them with antibiotics. So initially, we don't use any antibiotics. But if there's a jump in procalcitonin, we then try to treat it with bacterial infection.
Okay, so I'll come to that. If the patient develops hypotension, the first few days, you said that it's mainly because of the increased sedation that was easily manageable with vasopressor. But when the vasopressor requirement really goes up, and if the patient is in shock, then you said with procals going up, you look for secondary infections and treat it. Having said this, all the patients in our ICU can get secondary infection. But are you using any antibiotic prophylaxis in the beginning itself? Does they really help? Because in the Chinese treatment algorithm, in all the cases, they were using prophylactic antibiotics. Is it really helpful, or it is harmful, or it doesn't help? Or what's your protocol? Do you use a prophylactic antibiotic regimen when you intubate the patient, or you don't use anything? Only when the patient develops a shock or a rise in inflammatory markers or end organ dysfunction, then you send the cultures and you start empiric antibiotics. Dr. Ravi?
Okay. As I mentioned, we don't have access to procalcitonin. unfortunately, because of problems in the biochemistry. So what we do is we start empirical antibiotics, any patient coming to the hospital, and then we send all the atypicals, including Mycoplasma, Pneumococcus legionella. What we have found is about 15% of these patients, even when they come, they have some superimposed bacterial infection. So that is what we found from our cultures. So it's not just COVID alone, but at least 15% have. So that's the reason we start them on broad spectrum antibiotics with atypical cover. And then as the day passes on, go on.
So I hope that in some of the patients, the test also might be turning out as COVID negative. So how does the strategy change at the point of time? Do you use a routine H1N1 treatment protocols as well for all these patients?
No, we don't use any. We don't use any antiviral. We just use empirical antibiotic, broad spectrum. According to a protocol, we use tazocin and doxycycline to start out with. And after that, once you get the result, you rationalize. But as soon as you hit day 4 or day 5 on the ventilator, you see that spike in CRP again in this patient because of a ventilator-associated pneumonia. And then also Lyme by that time would be there for about 5-6 days. So eventually all these patients will end up on some antibiotics at least. But we start earlier because we can't rule out by using a prophylaxis.
Dr. Sanjith, what is your protocol?
Yeah, so pretty much it's the same. We are not using any antiviral, but what we for COVID-19. But what we are doing is we're starting all patient on piptazo and minocycline plus the addition of oseltamivir. But at that moment we are sending a biofire. The moment we get it negative, we switch off everything excepting the piptazo. The piptazo remains throughout the.
Okay.
So we don't use any HCQ. We don't use anything else. That's all.
All right. So when the patient is in shock, there are a lot of possibilities. It could be even a myocarditis, and like you rightly said, we'll screen the patient with echo and look for cardiac dysfunctions and markers, everything. And having said that, how does the cytokine storm plays a role here? Or is patient rapidly going in for renal dysfunction, recurring CRRT or end organ dysfunctions? How is the spectrum of things happening in these patients? Are they going in for a very profound shock or a refractory shock kind of stuff with the rapid progression to end organ dysfunction? How is the progress like when they develop shock in the later part of their stay in ICU? Dr. Ravi?
So most of the patients are relatively stable. So yes, the kidney gets hit, but half of the problem with regard to the kidneys has been self-inflicted by us because we try to reduce the amount of IV fluid for these patients. Because these patients are coming to the unit with huge amount of deficit. So they are unwell for about 7-10 days, no food, minimal water. So quite a lot of things going on. And then having PEEP, even 10 or 12 for a few days, gets the kidneys hit first. Our hospital has got huge amount of Afro-Caribbean population. They go into renal failure a lot more quicker. So our incidence is much more higher compared with Asian and Caucasian population. With regard to the myocarditis, I haven't seen them attacking the patient early. It is usually around day 7, day 10, depends upon. I've seen it's happening with day 4, day 5 as well. And when it happens, this myocarditis, it hits seriously. You see the ECG changes happening and the blood pressure dumping down very quickly. Once it hits these patients badly, because they're already ventilated, they're already on hemofiltration, it goes downhill very quickly.
Okay. So that's what pattern you are seeing. And Dr. Kishore, you have something to ask on this about the hemodynamics and the organ dysfunction, because you are reading that.
Yeah, I mean, once you go into the cytokine storm and you have multiple things happening where you need multiple support, is there a role for using cardiac output monitors and going by that? Are you routinely using that, or do you think because lack of resources it's not being used? But does it? I mean, I think from the intensive care perspective, it might provide more information at that point. What is your take on that?
So,
like
but the first,
There were some, a lot of cases you see a lot of fluid deficit because we are overzealously targeting the lung and removing the fluid, restricting the fluid, using enormous diuretics to keep the lung dry. But at the same time, we are compromising the hemodynamics and we land up in a iatrogenic kind of stuff where, our kidneys don't work well because of these. So target should be euvolemia, like Kishore rightly said. And do we empower or do we upgrade our monitorings to precisely treat those patients? Does that help? Dr. Ravi?
Yeah. So what we do normally is as soon as they end up on the ventilator in the unit, put them on the cardiac output monitoring. The standard monitoring that we have here is Bidkar. So we do that at least for 24, 48 hours. So most of the patients need fluid challenges during this period. So we don't look at the fluid balance chart at all for the first 2 days. And after that, once we feel they are well filled, then you maintain a fluid balance target. The first 24 or 48 hours, we keep it. And then after that, once they reach a stage, we take it off. But this myocarditis usually happens all of a sudden. Few instances I've seen just out of the blue it has happened.
Okay. Dr. Madan, you have something to add on this?
Very few patients end up with multi-organ impairment. Most of them remain as single organ. So far, if acute kidney injury happens, it tends to be self-limiting, resolves reasonably quickly, probably with better fluid management and probably backing off on the PEEP. In our unit, probably out of the 11, none of them are on renal support at this point in time. A few of them were on it before. I would say it's not very common. It may be ethnic driven, and initially, yes, slightly we allow a positive balance, but afterwards we tend to run them relatively dry. Once you start to see the urea climb up, the sodium climb up, we then go out with replacing with the nasogastric water.
So coming to that, you try to wean off these patients, and it said that a lot of patients you had difficulty in weaning, and a lot of patients landed up in re-intubation. Do you go for a tracheostomy early, or you wait and go for a late tracheostomy? And is the intubation rates are they really high, or it's like any other normal weaning patients? We wean the patients when the lung condition improves. Dr. Madan, you take.
I think this disease process is longer than our conventional ARDS management. So far, if you see the IGNARC data as well, nearly 40-50% of the patients haven't left the intensive care. So even our first cohort of patients are just about leaving the intensive care. So the average stays are probably around 14 to 17 days. So the Italian data is pretty similar as well. So even if they're on CPAP, non-invasive support, they tend to need it for at least 7 to 10 days. So nothing is going to be a straight quick fix. They're going to be there for a little while. And regarding re-intubation, extubation strategies and things, what probably happens is these patients cough quite a lot on the tube. So there is definitely an element of airway swelling. And because you put them at least 4 to 5 episodes of proning for 16 hours, they certainly get airway edema. So that probably contributes. And moreover, we tend to wait for the viral load to be low before doing tracheostomy. So because we had a few ENT surgeons die within the country when they did airway related procedures. So as a consequence, there's a slight backing off on doing an early tracheostomy. People tend to wait till the viral load is very low, or at least they are going to be COVID negative. So hence, nearly 14 days of ventilation with a tube, there is going to be bound to be airway edema. So if you extubate them, they probably go into upper airway problems. Our strategy is to give them at least 24 hours worth of dexamethasone and then see whether we can reduce the airway swelling and then aim for an extubation. But we are more now heading towards rather not extubating, but to go towards tracheostomy. So even today, I did 2 tracheostomies before coming for this webinar.
Okay. So there are quite a lot of interesting points, isn't it, Sabah?
Yeah, I mean, I just wanted to put in this question. When we talked about the inflammatory markers, and then there is always this talk about cytokine storm, wherein patients go from one extreme, deteriorate within a few hours' time. I just wanted to ask people who are looking after, is there any role for filters, cytosorbs, cytokine filters, basically? Has any thoughts been put into it? Ravi, Madan, maybe.
So again, you're looking at the filters that we have here. You're looking at higher kind of exchange rate. Is that right? Yeah.
No,
Yeah.
not the CRRT filters. I'm talking about cytokine filters in conditions of very high inflammatory
Yeah.
cytosorbs.
So we don't have access to those filters here, unfortunately. And even the normal filters that we're running, we're struggling with running them longer than 24 hours. For some reason, these patients are so much procoagulant. And even in spite of systemic anticoagulation, your filter clots up quite often and very quickly, even in spite of having good access. This is happening more and more. It is not just with our center alone, but with most of the centers in the country, big centers in the country as well.
Dr. Sanjith, how is your weaning going on?
So the Bombay, I mean, Bombay is witnessing one of the largest number of cases, and we are kind of divided among us as to when we should tracheostomize. So as it is in critical care fraternity, nothing, the change is the only thing that is constant. So there's a few of our colleagues who's intubating, who's tracheostomy, doing a tracheostomy very, very early, 5th or 6th day, but I believe it doesn't, as rightly put, why should we stress ourselves on the trachea when we can wait for a longer period of time? It's the fact of the aerosolization that occurs. So I have not seen so many cases, but the cases that I have seen, we want to keep the patient ventilated for a long period of time and hope that we can avoid the tracheostomy in the first place. I completely agree with Madan's view that doing a tracheostomy can be challenging for the operator there, and I would not like to do it only driven to it. Yeah.
So what we learned is there is definitely a significant risk of reintubation, if not related to the pulmonary mechanics. It's related to all the therapies we did, including proning, and we could land up in a lot of laryngeal edema, and that may necessitate us to go in for reintubation. If the reintubation rates are high at a later part in the UK, they're practicing tracheostomy especially when the viral loads are a bit low. And some of the consultants in India and Mumbai in certain centers, they are going in for early tracheostomy. And about the cytosorb, it's questionable, and depending on the availability, it is used in some of the centers. They don't have access to that. And now we'll go into certain questions, and I used to say, whomsoever write the guidelines, because the number of guidelines have also become epidemic. We are getting a lot of guidelines daily from various societies and various forums, that it has become a epidemic, not pandemic. So all the guidelines should mention very clearly that there is no effective proven magic bullet for treatment of COVID. That's must. There are a lot of trials, and even the presidents of powerful nations saying that they have got some magic bullet which is working. We'll just go through that one by one. Just wanted to know briefly, when do you use these therapies, or you don't use at all? What is your practice? Because so many of our viewers were also asking about that. If you see the question section, many of them are using about this. So you're talking about this. Sorry. So let us go one by one. Hydroxychloroquine, chloroquine. Let me start with the very popular guy first. Okay. So you can pitch in and tell about your experiences one by one. Dr. Ravi.
Okay. Unfortunately, I'm not qualified to mention or say anything about this drug, because we're not allowed to do any experimental drugs in UK. The only way that you can treat your patient with experimental drug is by participating in a trial. So our center is Sorry?
So you are not using routinely?
Not routinely. We are not allowed to use routinely. So we can only recruit patients into trial. So at the moment, we got patients in a trial called as recovery trial, which has got hydroxychloroquine as one arm and a couple of antiviral drugs on the other arm. I think Rutinavir, Lisumavir, and then standard treatment on the other arm. So,
Dr. Madan, your experience also should be the same then?
Exactly the same. Apart from the remit of participating in trials, we don't have access to any of the drugs which have non-proven, which are not proven. So, so as a result, we don't use hydroxychloroquine. We don't have remdesivir or tocilizumab, or even we don't even use.
Okay, I'll come one by one. So here, even our ICMR has recommended as a hydroxychloroquine as a prophylaxis for healthcare workers who are in close contact with COVID patients, and many of the healthcare professionals have taken hydroxychloroquine prophylaxis. But no, like you said, in unproven therapies, you don't have an access because you have a different kind of system there. Okay, Dr. Sanjith, your take on that? You are using regularly hydroxychloroquine for all your COVID confirmed patient or suspect patient?
No. See, what the government of Maharashtra has actually passed a regulation to actually use hydroxychloroquine and chloroquine as an advisory to patients who have respiratory of more than 30 and a saturation of less than 90. And on a couple of occasions have been bullied in by the CEO to actually use it because he will be penalized by the municipal commissioner or things like that. But I don't, I personally, and I will not use hydroxychloroquine and chloroquine till it is proven to be beneficial. And it does from the ward, when it does get, when the patient gets shifted from the wards into my ICU, I strike it off from my list because it might cause other problems. I don't use it. I will not use it.
Okay. So having said that, there are studies which, preliminary studies, small non-randomized trials, which show that when combined with azithromycin, the viral elimination of when they test at the intervals, the viral load is very, very low. So azithromycin, is that in use? Is that in your kitty? Dr. Madan?
Not at all. No.
Not at all. Okay.
No,
So
I think we will get answers for all these drugs in our next pandemic.
Okay.
At the moment, the only thing that I know is if you combine hydroxychloroquine and azithromycin, you can have prolonged QT interval. And there have been cases of people dying combining both.
Okay. So moreover, our journals and everybody are in a race to publish certain things. Even with the 5 patients, 6 patients, they are publishing, and they are giving a conclusion on outcomes, even reputed journals. And this study is a negative study about hydroxychloroquine and azithromycin combination. And what about remdesivir? It is used for compassionate use in clinical trials, and many centers do practice in US, I believe. I don't know, in India, we'll not be able to get that, but in UK, is that in your kitty, in the clinical trials? Are you part of some trials? Are they using in some centers?
Some centers are using remdesivir in UK as a part of a trial, but our center will not part of this trial.
Okay. So one of our viewer is surprised to know that is hydroxychloroquine not a prophylaxis in population in UK. So even in confirmed cases, you are not using it. So that's the answer here. They are unproven therapies. There is no magic bullet. That's what the experts believe. Most of our experts at least believe. So out of compulsions, out of some government directed, see, most of the times the medical bodies give guidelines, but in some instances, even the government gives guidelines on how to treat the patients. So based on that, it has been implemented in some hospitals. So remdesivir again. So this is also one study which was published in New England Journal of Medicine of the compassionate use of remdesivir for patients with severe COVID. So when evidence failed to delineate therapies, this is what happens. So how about antivirals, the Calitra, the lopinavir-ritonavir combination, or instead of lopinavir, the darunavir? So are you using that, Dr. Madan?
Only part of the recovery trial.
Okay.
The patients only get when they are randomized to this part to antiretrovirals in the trial. Other than that,
who is conducting the trial? I believe the Solidarity trial.
It's from Oxford.
Yeah.
Okay. And it is funded by the National Institute of Health and Research.
Okay, all right. Dr. Sanjith, how about in India?
No, see again. This is started on the in the wards, and by the time the patient comes into me, he's got some GI upset and things like that. I just switch it off. I don't know. In the wards, the doctors in the wards seem to be wanting to use these drugs. I think it's probably because of the reason that the government wants us to use them. But otherwise, the moment the patient comes into the ICU, I'm off these drugs. These don't work. It'll just cause more problem. As someone rightly put it, it will just cause side effects, nothing more than that.
Okay. So, how about this IL-6 antagonist like tocilizumab, and are you using that when the patient goes in for severe hemodynamic compromise and things like that? The patient is not really up. Any
We
experience
don't even
on this,
measure.
doctor?
We don't even measure IL-6.
Okay.
Yeah.
So
So
that's yeah, Sanjit. Yeah.
So there is one hospital today who has just started tocilizumab, and I'm really interested to know what happened to the patient. It's my patient in another hospital, and they found the ferritin levels to be alarmingly high. They measured the fibrinogens that had also gone up. They measured the D dimers, which was in the thousands range, something like 3,000s. They haven't repeated a CT. The patient has gone from a saturation from 90 to 82, and they are on a CPAP, and they have tried 400 milligrams of tocilizumab just maybe an hour back. So I'm interested to know what happens to this patient. Of course, this is just one case, but let's see what happens. Probably I'll tell you tomorrow what happens.
Okay, so there are concerns from our viewers saying that if at all later on this solidarity trial or some other trial show that hydroxychloroquine azithromycin is going to do wonders, then are we not ethically bound when nothing is there? Just let us give something. So is that the way to practice, Dr. Madan?
That's not the way to practice. So we are bound by what we know at this point in time about the disease process. So you can't hypothesize what may happen in the future. So at this point in time, what is the current evidence that is practiced by everybody, and what harm it could cause? So if I give a drug that doesn't probably benefit, but if it then causes a QT prolongation or a cardiac arrest, then I'm more liable for the problem for using a drug which is off license with non-proven benefits, with side effects or risk of harm.
Okay. So about ribavirin, I think your answer should be no.
Absolutely.
Okay, right. Dr. Sanjit, any use of this drug in our setup?
No, absolutely not. No, not till now. Not till now.
Okay. So there is a some group in US. They promote a lot of cocktails. You know about this the protocol, the vitamin C protocols which we use in sepsis, or the vitamin C, thiamine, and low dose hydrocortisone. Similarly, the zinc and vitamin C has been hailed as some savior in these kind of problems, with a lot of theories behind that. So, what is their role? Is it in a routine drug list, or you don't do that in UK, Doctor Madan?
We don't use it routinely. What I can see as an offshoot of this is these are interventions with a low risk of harm. They can probably sneak into protocols because they don't cause a great deal of damage. But whether they make a difference, I don't think there is a great deal of evidence out there. So we just do standard ICU management without any disease modification. The only time we use some sort of disease modification is when we use methylprednisolone. Apart from that, we don't use any other disease modification.
I'll come to methylprednisolone. And Dr. Ravi, your take on this?
So,
Zinc, vitamin C.
so we don't use zinc routinely in any of these cases. The only thing that we do is any patients who come to the intensive care on a routine basis, we give this vitamins, which include thiamine and vitamin C, the papaverine ampules, which we give for 3 days. So we just continue to give for all these patients who come in.
Okay. So, Dr. Sanjit, you have this habit of using these things?
Yeah, this is only for sepsis-induced ARDS on background of having COVID-19, which is kind of doomsday for the patient. That's the time probably we use vitamin C as part of the citrus ALI kind of algorithm. Yeah.
Okay. So a lot of interest has been created on this convalescent plasma because the JAMA, I think, they published outcome of 5 or 6 patients, and they claim that and it is found to be efficient. And there are a lot of articles circulating in the net and asking for convalescent plasma. And even in some of our government guidelines, this has come convalescent plasma and PRBC transfusion. So plasmapheresis already we discussed. So convalescent plasma in severe COVID patients where the patient is going down? Is there a role? Have you used it? Or will you intend to use it if you get such patients? Dr. Ravi?
No, unfortunately, we don't have evidence to support it, or proper evidence to support it. So at the moment, these are all experimental therapies. So until it comes with the guidelines, we will not be able to use these therapies. With regard to the packed red cell transfusion, you go with whatever your transfusion trigger is, and based upon that, you give red cell transfusion. But the other 2 modalities we haven't used so far.
Okay. Dr. Madan?
Same. All of them are experimental. Transfusion triggers are 7 or less than 7. Until then, we don't transfuse. And convalescent plasma, no. We don't know what the side effect profile and things of that is going to be. So without having detailed information about some of these therapies, I don't think it's recommended in any way.
Okay. So some are wondering, Dr. Ravi, you are not mentioning any drug. What are you treating these patients without any drug? So
that is the problem, isn't it? That is the problem, isn't it? So we can give only supportive management. Is there any confirmed or any kind of drug that has been proven by the trial that works for these patients? At the moment, the answer is no. Whatever is, people are giving trials, experiments, and all those things. So supportive management, treat the secondary bacterial infection, and then your ventilation strategy based upon which arm they are in, whether it is H or L. Anticoagulation, you're not going to cause too much harm by anticoagulating them if the D-dimer is high and if the kidneys get hit. These are all the things that you're using.
So is it this kind of anxiety from even from our own medical professional which makes us take knee-jerk reactions and then ask the government to publish certain things that use these drugs when they're nothing to offer, just use that. We need to have very good confidence of our system to strengthen our critical care system to provide the critical care. At the most, it's not just supportive care, it is critical care. When you provide that, when you protect the lung and maintain the hemodynamics, the virus, whatever the damage it has caused, yes, patients will die. There will be a mortality rate. Even for normal ARDS of any other cause, there is a mortality. And with good critical care alone, they can come around. So we are always aiming for magic bullet. And because of this anxiety, not a lot of drugs are added into the kitty, and then it is being used irrationally. If you're talking about one drug, then that's not about only one drug. There are multiple drugs. So how many drugs you will be using irrationally? So that is a question. So that is not the way to practice. That is what clearly our panelists and all the panelists are in agreement. Am I right, Dr. Sanjith?
Absolutely. I mean, we have to. We are clinicians. We aren't, any other profession. We should analyze the evidence and then take a call and treat them, and not just subject them to side effects of medicines. You're absolutely right.
Okay, so hyperbaric oxygen, it's out of question because the theory itself was a myth, isn't it? Yeah. Okay. Are you even giving thought about it? Hyperbaric oxygen in this kind of state.
Look at the practicalities of transferring a patient to a hyperbaric oxygen chamber, and then after that decontaminating the unit for unfounded benefit based on hypothetical indication. And what if the patient arrests inside there? How are you going to resuscitate this patient?
Okay, so these are all just easy to write in your blog, but it's not practical, or it's not scientific as well. So what therapeutic anticoagulation, we talked about that, and we talked about biomarkers and how they will guide in therapeutic anticoagulation. In spite of therapeutic anticoagulation, you're seeing as evidenced by the block of the CRRT catheters, the frequency with which it has to be changed. You can see that these patients are really hyperthrombotic, and there are some studies which we came across in which IV thrombolysis was used, isn't it, Sabha? So you want to have something on that?
Yeah, I mean, quite interesting, because everything is based on this pulmonary vascular thrombosis or microthrombi mechanism that has been proposed. But area of IV thrombolysis, I've been hearing from friends of mine from the US as well, but I don't see anybody using it widespread. I haven't heard anybody using it widespread. Yes, I hear a lot about anticoagulation, both therapeutic anticoagulation, but nothing about IV thrombolysis, though there has been some people talking about it. But well, Ravi and Madan might have a better answer.
Madan, you have to say anything on this? Yeah. Is it in protocol?
CTPA proven large clot in the main pulmonary main pulmonary tree. Evidence of right heart strain, hemodynamic instability. So it's like as if it's a PE. So if it's a PE, then we treat it with Altiflex, and then after that continue regular heparin infusion, and then switch over to therapeutic anticoagulation. But in the absence of it, no routine thrombolysis. It's only therapeutic anticoagulation based on D-dimer assays and levels.
Okay. So,
sorry, can I just clarify myself? So it's just as a treatment for PE.
Yes,
isn't it?
If you have proven PE or evidence that this patient is hemodynamically unstable and echo shows a big right heart and evidence of significant right heart strain, then we tend to thrombolyze them and then continue with therapeutic anticoagulation. Other than that, not on a routine basis.
The usual indication for a PE thrombolysis.
Yes.
Okay.
Okay. So here comes a very popular thing about steroids, methylprednisolone. I've seen blogs where even junior doctors write about this methylprednisolone. This is not a viral pneumonia, it is an inflammation. Even in the early part of the disease, we started using and we have seen remarkable outcomes. That is one story. The other story from the Chinese is they really had this methylprednisolone in their kitty when the patients went in for ERDS. Of course, a low dose methylprednisolone strategy, and they claimed in a small study that these patients actually did well. So methylprednisolone, whenever we talk about ERDS, even it's disproven in so many studies, there is still a role, and so many clinicians still practice steroids in their practice. So in this particular scenario, is it harmful? Is it going to be beneficial if you introduce in the particular time period of the patient's disease process? Dr. Madan, your experience, Dr. Ravi, your experience, and I'll come to Dr. Sanjith. Yeah.
I mean, we don't know is the answer. We use it based on the inflammatory stage. Nobody knows the right answer, how early, what is the dose you need to give, and what should be the inclusion criteria for these things. What we tend to do is, if the risk of bacterial infection is low, then, or if their inflammatory status, that is based on their ferritin, their LDH, it's pretty high, and they're in a very hypermetabolic state, then we tend to start on low dose, that is 1 milligram per kilo of methylpred. But we don't use it on everybody. We try to have screening criteria. If the patient fulfills the screening criteria based on whether they are the inflammatory stage, then we tend to use this. But other than that, not on a regular basis. We take advice from tertiary centers about this as well. So risk benefit for every patient is carefully weighed before commencing steroids.
Okay.
With our experience, early ARDS definitely we are not using, or at least for the first 7 to 10 days we are not using, because we are always thinking about a secondary bacterial infection, HAP and line sepsis. But once you rule out down the line, and then you still have high amount of oxygen requirement, and you still are in the inflammatory phase after ruling out the infection, we have just started using, this is on day 10, day 14, down the line. They're still on the ventilator with high oxygen requirement, with high inflammatory mediator. We have started using the Puducherry 2 milligram per kilogram methylpred on few patients.
Dr. Sabha, you have anything to ask in that?
No, I mean, there's something new. So I would like to know in future how these patients fare. As Dr. Madan said,
Dr. Sanjith, is that in your protocol?
On steroids, yeah. So, yes, so steroids, unfortunately, I did use it on one patient who behaved very, very badly on cytokine storm. And just one patient is not experienced at all. So in that one patient, I did give. The ferritins were high, the D dimers were up, the LDH was up, and this guy was spiking fever at 104. It looked like a perfect storm actually. And in that patient, I did give 40 milligrams of methylprednisolone, and it was a zero point 0.5 milligram per kilogram. I thought I'll use it for around 3 days, but I lost the patient on the second day. So I don't know what to do, and I'm waiting for evidence on this.
Okay, so as a compassionate use, you have used it. Dr. Kishore, you have something to say on this steroids? Okay, I'm not seeing him. Okay, then coming to the AC inhibitors and ARBs. So there are initially there were fear of using AC inhibitors and ARBs in this patient because of the viral pathogenesis. Are you discontinuing these ARBs because all the heart associations came together and said that there is no need to discontinue that? Obviously, they wanted to protect their results, but is that these patients, do they really don't do well, or do they have the issue? What is your experience on patients with AC inhibitors and ARBs? Dr. Madan.
I mean, our guidance has been that there is inconclusive evidence, and especially the risk of discontinuing it in the community on the vast majority of the patients by giving a blanket rule means there will be a lot more patients presenting with congestive heart failure. So what the Public Health England has said that is they should be continued, but that's out in the community. But when they come into the intensive care, generally we tend to stop most of the ACE inhibitors, mainly because of renal dysfunction, especially the septic population and the hypotensive population. So we tend to reinstate it slowly. I wouldn't say that for this specific reason that I would stop it, but generally we tend to stop most of the drugs and then reinstate them once they get better.
Dr. Sanjith, what is your practice?
So we don't stop the ACE and ARBs at all in the wards. But as Madan put it, once they come into the ICU, we first knock off everything and then slowly restart them. And there is really no relationship of ACE2 receptor. That's a completely different enzyme compared to what the ACE inhibitor and the RAS system is all about. So we continue them in the wards for certain. We don't stop it.
Okay. Now we have some viewers who are joined for a live discussion. First, I will invite Dr. Ranadir to ask his question. Dr. Ranadir Mitra, what's your question? What do you ask?
Good evening, gentlemen. I have only one question. During this pandemic time, am I audible? Hello?
Yeah.
Am I audible?
Yes, you are audible. Yeah, go ahead.
Okay, I have only one question. During this time, has there been any rise in number of cerebral infarcts coming in?
Okay, go ahead.
Yeah. So I'm asking whether there has been any rise in the number of ischemic stroke at this point of time.
So I think we discussed about this. We discussed about this thrombotic phenomenon which is happening. Patients, not only pulmonary vasculature, there is some incidence of rise in stroke as well. So, are you seeing in any of your setups that you get a lot of stroke patients? Because there were, maybe it could be incidental, but especially in US, the United States, their centers, they are reporting cases of stroke in COVID patients. Dr. Ravi,
we have seen a couple of patients present with confusion. So COVID positive, but then ended up having confusion and things. But they tested negative for all other viruses, and even lumbar puncture has shown that it's all negative for most viruses. So we don't know. We suspect there is a possibility, but it could be in the lower end of the spectrum. We haven't seen enough patients enough to comment on it. But from our limited experience, unless you subject them to very sensitive tests like MRI or MRA, and we'll not be able to find out from just basic CT scans on microthrombin.
Kind of encephalopathy. I think encephalopathy has also been reported as in some of the neurological journals. Maybe everybody want to pitch in during this COVID-19 time. Okay, Nandha, is that answered your question? Dr. Mitra?
Yes.
Yeah, thank you. Thanks for coming.
Thank
yeah.
you.
Yeah. So I got Dr. Rangarajan here. Dr. Rangarajan, what's your question? Yeah.
Hello. Just that in the US and the UK, there is anecdotal reports that black and ethnic minorities are not faring very well when they get into ICU with COVID-19. That's in general population. But speaking about healthcare workers, especially doctors and nurses, if you look at the mortalities in UK, about 90% are from black and ethnic minorities. And one of the theories floating around is that dark skin finds it difficult to produce vitamin D, especially when there is lack of sunlight, like in countries in UK. So Dr. Ravi might be more experienced with this because he see quite a lot of BAME population in his practice. So do you routinely check vitamin D levels in ICU patients?
So not on a routine.
Is there any role?
Yeah, not on a routine basis, but we do check once in a while. So, but we have started doing a bit more, and invariably, about 9 out of 10 patients who are admitted in ICU have got low vitamin D levels.
Okay.
So, do you supplement them as part of the supportive treatment?
Not on a routine basis, not now.
Association doesn't mean causation, and treatment of something probably wouldn't show that there's going to be benefit. So these are hypothetical things. I think there is a lot more social context to why Asians and ethnic minorities are affected more. The Asian people tend to be in bigger communities, so probably that could be linked to why they are affected. Whether the severity of it is high, it is possible. We really don't know the answer. I think at least in my part of the country, we don't have that big a spread or a greater representation of Asian people in the mix. So it is probably dependent on the demographics of which hospital that they come to.
Thank you, Dr. Rangaraj.
Thanks a lot.
Question?
Thank you. And I was just going to ask Dr. Sanjith. I mean, there's quite a lot of COVID-19 patients in Maharashtra. How is the incidence of the disease among healthcare workers, especially in doctors and nurses in Mumbai? Are they seeing like high incidence or more than expected incidence of COVID-19 in healthcare workers in terms of personal protection and things? Are they up to date?
Dr. Sanjith, yeah.
Yeah, good question. Good question. So, we are a setup where we have private hospitals and municipal hospitals. So it's purely left up to the private hospitals to provide the use of PPE, and the municipal hospitals, it's purely left to the municipality to their PPE. So there are so many different kinds of protective equipments that it becomes very difficult to which is the one we need to use. Coming to that, we do not have a very high incidence of healthcare worker associated cluster cases that we are seeing after treatment. They are getting it because they have been exposed to the virus without wearing a PPE rather than like this, because they have not segregated these hospitals completely. They have not done that bit where you screen and you go to a hospital. Still, multiple hospitals admitting normal suspects as well as COVIDs together, and that's the problem that's occurring in our setup. Yeah.
Thank
you, Dr. Rangaj. Thank you, Dr. Rangaj. So, Dr. Srinivasan is here. Dr. Srinivasan. One second. Yes, Dr. Srinivasan, what's your question? Yeah.
Sir, I want to know that what are the ventilator modes that you are using nowadays? People are telling more about the prone ventilation, especially patients are near ARDS.
So prone ventilation. You want to know about specific modes like APRV modes and what are the modes they are using?
Yes, sir. Yes, sir. Any advanced modes or any simple prone ventilation with the normal modes?
So,
okay, Dr. Ravi, yeah.
Okay. So obviously this is a difficult situation, and in difficult situation, use things you're familiar with rather than things that you haven't used before. You can try and do something, but first of all, start what you're comfortable with. So if you're comfortable with the volume control or pressure control ventilation, which is what you normally do, or a PRVC, a pressure regulated volume control. So you use the same mode, pressure control or PRVC, and use it when you prone people, just like when you prone for a spine surgery. Yeah. So the different mode apart from all these things is APRV, which is separate, which needs a bit more understanding. And then you can read from literature and do it. But prone ventilation is the one that has worked well with the basic settings that we do. If you are an ARDS, go for a bit more higher PEEP. But if it is a non-ARDS kind of thing, go for a lower PEEP.
Sir, I'm not.
Yes, Srinivas.
Please, sir. Please, sir.
Yes.
Dr. Madan, sir.
As Ravi said, whatever mode you're comfortable with, we tend to use APRV mode and another mode called BiPAP commonly. But it does not matter as long as you stick to the principles of the ventilation, which is allow hypercapnia, don't do damaging ventilation strategies, adjust your PEEP and FiO2 if they are in the low compliance category according to the ARDS net trial, use the lowest driving pressures, and keep the mean pressures or plateau pressures less than 25.
Thank you, Dr. Srinivas. Thank you for
you stick to those principles and possibly accept permissive the lower saturations, then probably you'll be okay.
Thank you.
Thanks, Dr. Srinivas. Thank you for coming and asking the question. So we are ending our coming towards the end of our discussion. Dr. Manish, your final comments on this. Dr. Manish, yeah.
Actually, I lost my connection in between, so that I could not listen to the whole talk. But we got a first-hand information how the patients are being managed there and how what we should do when this surge comes in India. So it was a nice discussion. So my one question is, can we identify responders versus non-responders? Or
in the beginning itself,
you want to say which we can see or look at in the beginning.
Basically, Manish wants to know which patients do well and which patients don't do well. Can we have a clue about them in the beginning of the treatment itself, especially when they are about to intubate those patients? Dr. Ravi?
At the beginning, if you are a male, start with sex. That's not important. You start at a much lower level. You got a lot of catching up to do. Because if you look at the male-female preponderance, it affects male 70% compared with female. So a female patient, you're starting at a good ground. You're right. And then the other comorbidities, I found diabetes, hypertension, obesity. These are the three things that when you start off with, which makes you starting at a much lower ground, an asthmatic and being on immunosuppressant. These five things. When you improve well with your CPAP within whatever time frame, then you've got a good chance of doing well. But if you start with the lower level with regard to the marker, like your very high CRP, low lymphocyte count, high serum ferritin, high D dimer, these are all markers which say you are starting at a not great level. You are starting at a much lower level. So you got to do a lot of catching up before you get better. So that's how you see. And again, as you see, every hour things will change, and you will see a patient on nasal specs today, and then tomorrow they will be on humidified oxygen, and following day on 100% oxygen. Next day they get intubated. So it's very hard to prognosticate starting with, but there are markers, and then you see how the markers are faring to prognosticate. So just one marker, one time is not alone enough. So you see how clinically they are doing well, and also how the markers are faring, and then you make a call. But once they end up in ARDS, then it becomes very difficult for these patients.
And another popular question is, how many of your healthcare workers are getting infected? Now, what is the incidence? Is it really alarming, and how are you adequately protected? Do adequate protection, does it make a difference? Because we saw that in China, in the initial lot, there were a lot of healthcare workers who were affected. Later on, when they made a stringent protocol with a separate COVID unit with all double protection PPEs, as per the published or unpublished the data which they provided, none of them got infected. So what is your status of healthcare providers there in your hospital and across the UK?
At the moment, our hospital, for the last 3 weeks, we got 200 inpatients with COVID. So wherever you go, the COVID is there, floating in the air. Yeah. So that's an important thing. And we are getting PPE, but so far, with regard to healthcare workers, 5 of my consultant colleagues have become positive, and luckily they all recovered. They're back to work after isolating them for a week. And about 10 trainee doctors have become positive, but they all came back working. So far, it hasn't hit anybody in the doctors community to end up in intensive care unit from our hospital. But we have few nurses. There's at least one nurse who's still on the ventilator, and a few other healthcare support workers who are all intubated and ventilated as well. Because the UK has reached the stage where there is no containment. It is a community transmission. So you're not going to get COVID by going to the hospital. It's there in the community everywhere, and it is transmitting quickly. So that's where we are. So as mentioned, there's one more thing that I want to mention. With all the medical personnel, there is no emergency in a pandemic. There is no emergency in a pandemic. You have to take, even if the patient arrests, you have to take your PPE before you jump on the chest or intubate.
Valid, very valid point. Dr. Sabha, your final concluding remarks and any questions?
Yeah. It's been a great 2 hours now. I'm glad Madan started with a positive note, saying that the case numbers have started coming down slowly, which is a very good news. Hope you guys get over this crisis very soon. And luckily for us, we are starting it much later than most of you guys have. So we have a lot more information about this problem right now rather than where you were when this problem started. That way we are lucky, and it's been absolutely useful session, both in the way of reassurance of the fact that you share the same ideas like what we do, and also sharing in your new ideas, what you have learned over the last few weeks, things, the way that things have evolved and all that. So it's been extremely useful session. Thank you very much, and good luck to you guys.
Dr. Sanjith, your final remarks.
Yeah, so someone really mentioned that COVID-19, some patients do well, some patients don't, some patients go worse. I mean, Kurt Cobain once said, if what you've done in your past life hits you again, I think this is all past life. So but as Sabha really put it, that we are actually having a heads up as compared to our colleagues in the United Kingdom. And thanks to you all for helping us out on it's been a pleasure being here.
Okay, thank you. And Dr. Madan, your final comments.
I would say that prepare for the worst, protect yourself, and then start preparing your teams to work together, and start practicing drills and things for most of the situations, so that when things come in high volumes, you guys are aware what to do and how to manage things. And the other thing that I would need to say is you got to be in constant touch with your management, because there's going to be a huge impact on your resources, the drugs, the way you manage it. So you may have to adapt your strategies on the move. So you got to have a lot of constant contact with your own groups, and working in small constant teams is going to help. So there is a lot more than just clinical management during a pandemic, which probably you guys should start preparing for now, which includes like stocking, and how to put the gown on and off, and how to where to take it off, how to isolate those zones. There's a lot of planning involved. So you've got to have a lot of your senior members on board enough to start the planning from now itself. So when the cases start to trickle in, you already are ahead of the game. Clinical management is only a small part of the whole game. You have to forget about it, and how to know how to manage the bigger picture when your system is going to be overloaded.
Okay. Now, I have to thank everybody, especially Dr. Madan and Dr. Sai for coming all the way to spend 2 hours to discuss various things. It's never complete. Yes, our viewers had some other views on certain aspects like employing therapies because it is a pandemic. We have to take chance and give certain drugs and therapies that the panelists completely differed. Yes, there are differences, and there is no absolute one way to manage these patients. But anyway, it was a very wonderful discussion, and I think we have got a lot of ideas from this discussion, and we should be well prepared to tackle, if at all, it happens, this pandemic in a way which we don't want that to happen. Thank you so much. Thanks for all the supporters who has been constantly encouraging us to do this program. Thanks for watching. We'll meet you with some other topic in the next session. Thank you.
Thank you.